Welcome to the deep dive. Today we're really getting into it with three major players in cardiovascular health: hypertension, heart failure, and ischemic heart disease. You sent over a fantastic set of materials for this, clinical notes, research bits, just packed with info. Our job to unpack all that, grab the key stuff, and, make sense of it together. Consider us your guides through the heart of the matter, literally.
Absolutely. And these conditions, they're so common, often linked. Understanding them is really crucial if you want to be informed about heart health. We'll look at how they're defined, the causes, symptoms, treatments, basically navigating what your sources lay out. Let's get started.
Okay, first up, hypertension, often called the silent pressure. Your sources define it pretty simply as persistently high blood pressure in the arteries.
Right, and the sources give us a really helpful breakdown of what high means using this classification table for adults. So normal, that's less than 120 systolic and less than 80 diastolic. Then there's elevated BP.
Okay.
That's where the top number, the systolic, is a 120 to 129. But the bottom number, diastolic, is still under 80.
Got it. And then you actually hit hypertension. Stage 1 is systolic 130 to 139,
Or that diastolic is 80 to 89. Stage 2, that's the more serious one, is systolic 140 or more or diastolic 90 or more. It's that persistent part that's key.
Mm-hmm. Your material also flags something called isolated systolic hypertension, ISH. See this a lot in older folks? The systolic, the top number, is high, like 130 plus, but the diastolic stays below 80. Important pattern.
Then there's something that, well, it just sounds bad. Hypertensive crisis.
Yeah.
That's when the BP goes way up, over 180, over 120.
Yeah, and the critical difference here, according to your notes, is whether that super high pressure is actively hurting organs right now. So a hypertensive emergency, that's the really dangerous one. Very high BP plus signs of acute damage to the brain, heart, kidneys. You get the idea.
Urgent.
Exactly. Then there's hypertensive urgency, still dangerously high BP, but without those immediate signs of organ damage. Still very serious, needs attention fast, but not quite the same level of immediate crisis.
Okay, so why does the pressure go up? Your sources talk about two main kinds. Yeah, the overwhelming majority, like more than 90% of cases, is what they call primary or essential hypertension. And the tricky thing is, we don't really know the exact cause. It's complex. The rest, less than 10%, is secondary hypertension. That means there is a specific identifiable cause, often chronic kidney disease or maybe problems with the arteries feeding the kidneys, renovascular disease.
And useful point from your notes, some medications can actually push BP up. Things like, corticosteroids, common NSAIDs, even some antidepressants like venlafaxine are listed, worth knowing.
Definitely. And that silent pressure name is so fitting because often people feel totally fine until hypertension has caused some serious long-term damage. The sources are clear. The big risks, the things that sadly often lead to death, are strokes, cardiovascular events like heart attacks, and kidney failure. It's a stealthy threat.
So how does it show up? Initially with primary hypertension, usually nothing. You feel okay. Measuring BP is the only way to catch it early.
Right. But if it's secondary, you might have symptoms linked to whatever's causing it, like kidney disease symptoms. And those really worrying signs of end organ damage, eye changes, confusion, chest pain, kidney failure signs, poor circulation, those tend to appear in those severe hypertensive emergencies.
So diagnosis really hinges on those BP readings. Your material stresses it's not just one high number. It should be based on the average of measurements from two or more separate visits.
Mm-hmm. And when we talk about treatment, the main goal, laid out clearly in your sources, is simple. Reduce the risk of those major CV events, heart attack, stroke, death. The guideline most often mentioned, the 2017 ACC-HA one, aims for a low 130 over 80 for most people.
But there's a key difference for older patients, right? Especially if they're in care facilities or have a lot going on health-wise.
Yes, exactly. For them, a slightly more relaxed goal for the systolic, maybe under 150 or under 140 if it's tolerated well, is often considered acceptable. It's about balancing the benefits of lowering BP with the potential downsides for that individual.
Makes sense. And the foundation seems to be non-drug approaches. Your sources really hammer home that lifestyle changes are vital for everyone with elevated BP or diagnosed hypertension.
Yep. This is where we hear about losing weight if needed, following the DARESH diet, lots of fruits, veggies, low-fat dairy, cutting back sodium, ideally under 1.5 grams daily, getting regular aerobic exercise, maybe 90, 150 minutes a week, and watching the alcohol intake.
And your notes make a point about smoking.
Big point. Even though quitting smoking doesn't directly lower BP itself, it massively cuts overall cardiovascular risk, so it's strongly encouraged. A crucial piece of the puzzle.
Okay, let's dive into the medications, the pharmacologic side. The choice seems to depend on how high the BP is and if there are other health issues, these compelling indications.
That's right. For someone just diagnosed with stage 1, usually starting with one first-line drug is the way to go. But if they're already at stage 2, your sources suggest starting with 2 first-line meds together, often in a combination pill.
And the big 4 first-line choices listed are ACE inhibitors, ARBs, calcium channel blockers, and thiazide diuretics.
And those compelling indications. They steer the choice. Like, if someone have chronic kidney disease or heart failure or ischemic heart disease, ACE inhibitors or ARBs are often preferred. Beta blockers come in strongly for IHD and heart failure, and CCBs are noted for IHD and specifically as being effective in Black patients.
Okay, let's walk through these major classes based on your notes. ACE inhibitors first.
Sure, ACE inhibitors, drugs like lisinopril and enalapril, ramipril, they work by blocking an enzyme that converts angiotensin I into angiotensin II. Now, angiotensin II is a really potent substance that constricts blood vessels and signals the body to hold on to salt and water, raising BP.
So blocking it helps relax vessels and lower volume?
Exactly. Sources mention starting low, going slow with dose increases, side effects. Well, you can get a drop in BP, especially when starting. They can also bump up potassium levels, so that needs checking, especially in people with kidney issues or those on other meds that affect potassium.
And the infamous cough.
Ah, yes. A persistent dry cough happens in maybe up to 20% of people. It's thought to be due to blocking the breakdown of something called bradykinin. It's annoying, but not dangerous. More rarely, but seriously, there's angioedema swelling, potentially of the airway. And critically, ACE inhibitors are a definite no-go during pregnancy.
That cough is a big reason people switch, which leads us to ARBs, angiotensin receptor blockers.
Precisely. ARBs like losartan, valsartan, candesartan, they work a step later. They don't stop angiotensin II from being made, but they block the specific receptor it needs to attach to cause its effects.
So similar outcome, different mechanism.
Right. And because they don't mess with bradykinin in the same way, they are much less likely to cause that dry cough. That's a major advantage. Overall, fewer side effects, but they still share some risks with ACE inhibitors, like potential kidney effects, high potassium, and, just like ACEs, contraindicated in pregnancy.
Okay, next, calcium channel blockers, CCBs.
CCBs work on calcium movement into muscle cells. There are 2 main types described in your sources. The dihydropyridines, or DHPs, like amlodipine or nifedipine, they mostly relax blood vessels, lowering resistance.
And the other type.
The non-dihydropyridines, non-DHPs, like verapamil and diltiazem. They also relax vessels, but they have a bigger effect on the heart itself, slowing the heart rate and reducing how hard it squeezes.
What does that difference mean practically?
Well, the DHPs, because they relax vessels so much, are more likely to cause things like ankle swelling, headache, flushing. The non-DHPs, because they affect the heart muscle more, can sometimes slow the heart rate too much and are usually avoided in patients with systolic heart failure, which we'll get to. And verapamil specifically is known for causing constipation.
Gotcha. Then thiazide diuretics.
These are often a first choice. They work in the kidneys to help flush out extra sodium in water, reducing blood volume and pressure. Your material points out that chlorthalidone might be preferred over hydrochlorothiazide, especially in tougher cases, because it's a bit more potent and lasts longer.
Side effects to watch for.
Mainly electrolyte issues. Low potassium, low magnesium are common. They can also potentially raise blood sugar, uric acid, which can trigger gout, and cholesterol levels. Need monitoring.
Are there other diuretics mentioned?
Yes, loop diuretics like furosemide, they're much stronger at removing fluid, so they're not usually the first pick just for BP, unless there's also significant edema like in heart failure or if kidney function is quite poor. Side effect profile is similar: electrolyte loss, risk of dehydration.
Okay.
Then there are potassium-sparing diuretics like spironolactone or amiloride. Weaker on their own for BP, but often used with thiazides or loops to help prevent that potassium loss.
And spironolactone and eplerenone are also called MRAs, right? Mineralocorticoid receptor antagonists.
Exactly. They block aldosterone, a hormone involved in saltwater balance and also fibrosis. So they're useful in resistant hypertension, where aldosterone might be high, and they're a key part of heart failure therapy too. Main concern is hyperkalemia, high potassium, especially combined with ACEs or ARBs. And spironolactone can cause breast enlargement in men, gynecomastia. Eplerenone is less likely to do that.
All right, moving to beta blockers.
Beta blockers like metoprolol, atenolol, carvedilol, they slow the heart rate, reduce the force of contraction, lowering BP and the heart's workload. Your sources say that while they lower BP, they are especially key first-line drugs if the patient also has a compelling indication like heart failure or ischemic heart disease.
Are some preferred over others?
Yes, certain ones like carvedil, metoprolol succinate, and bisoprolol have strong evidence for improving outcomes in heart failure specifically. Side effects can include fatigue, feeling sluggish, slow heart rate, cold extremities. Some can affect blood sugar control in diabetics.
And your notes really emphasize not stopping them suddenly.
Absolutely critical. Stopping abruptly can cause a rebound effect, sharp rise in heart rate and BP, potentially angina, or even a heart attack. They must be tapered off slowly, usually over 1 to 2 weeks.
Okay. What about some of the other classes mentioned for more specific roles?
Let's see. Alpha-1 blockers, like prazosin. They relax vessels but are usually add-on therapy, often helpful in men who also have BPH, benign prostatic hyperplasia. Central alpha-2 agonists like clonidine or methyldopa work in the brain to reduce signals telling vessels to tighten. Clonidine, sometimes for resistant hypertension. Methyldopa is a classic choice for hypertension during pregnancy.
Right, pregnancy was a special focus.
Yeah, very important. Preeclampsia can be dangerous for both mother and baby. Delivery is the ultimate treatment. For managing chronic high BP during pregnancy, methyldopa is often first choice due to its long safety record. Some beta blockers like labetalol and CCBs are alternatives. For severe acute spikes in pregnancy, IV labetalol or hydralazine are used.
And the sources also noted specifics for Black patients and those with lung disease or PAD.
Yes. For Black patients, CCBs and thiazines are often highlighted as particularly effective first-line options. For lung disease like asthma or COPD, the fear used to be beta blockers worsening breathing. But the sources clarify that cardioselective beta blockers can generally be used safely. And for peripheral artery disease, PAD, even though theoretically beta blockers could worsen leg circulation, data suggests they don't really worsen claudication symptoms. So treatment generally follows the same principles.
So how do you know if the treatment's working?
Regular follow-up is key. Checking BP in the clinic, comparing with home readings, usually about 4 weeks after starting or changing meds. Once the goal BP is hit, monitoring every 3-6 months is typical, always checking for side effects and making sure the patient is sticking with the plan.
All right, that's a good handle on hypertension from your sources. Let's shift gears to the second condition, heart failure. Your material calls it the pump problem.
And that really captures it. Heart failure isn't the heart stopping. It's a syndrome where the heart muscle can't pump enough blood effectively to meet the body's demands. It's due to some abnormality in the heart structure or function. This can be a problem with the squeezed systolic function, meaning the heart muscle isn't contracting forcefully enough. Or it can be a problem with relaxing and filling diastolic function, where the muscle is stiff and can't fill properly between beats.
And the sources classify this based on the ejection fraction, the LVEF.
Exactly. LVEF measures how much blood the left ventricle pumps out with each beat. If it's low, 40% or less, that's heart failure with reduced ejection fraction, HFrEF. That's the systolic problem, weak contraction.
Okay.
If the LVEF is normal or near normal, 50% or more, but the person still has HF symptoms because of filling issues, that's heart failure with preserved ejection fraction, HFpEF. That's the diastolic problem, stiff ventricle.
What leads to this pump problem? Your sources point back to coronary artery disease and hypertension as the big culprits, clear connection to what we just discussed.
Right. And here's where the body's response gets kind of counterproductive over time. When the heart's output drops, the body freaks out a bit and activates neurohormonal systems, the RAAA system we talked about with hypertension, and the sympathetic nervous system, the fight-or-flight system.
Which initially tries to help, right? Speed up the heart, hold on to fluid.
Yes, initially it compensates, but your sources explain that this chronic activation is actually harmful long-term. It leads to changes in the heart muscle itself. It gets thicker, changes shape, this process called ventricular remodeling, which ultimately makes the pump function worse and causes the symptoms.
Speaking of symptoms, what does heart failure actually feel like for someone?
The main things are shortness of breath, especially when active, that's dyspnea and fatigue. This leads to that reduced exercise tolerance.
Other classic signs, often from fluid buildup, include needing pillows to sleep propped up, called orthopnea, or waking up suddenly gasping for air, PND, paroxysmal nocturnal dyspnea, also a cough, swelling in the legs or abdomen. Your notes also mention vaguer things like poor appetite, nausea, weight gain.
Diagnosis involves looking at the whole picture. Symptoms, physical exam, imaging like chest X-ray or echocardiogram. The echo is crucial for measuring that ejection fraction and seeing the heart structure. ECGs too.
And the sources mention the NYHA functional class, which doctors use to grade symptom severity based on activity limitation, from class 1, no limits, to class 4, severe limits even at rest.
What are the goals when treating chronic heart failure?
Really, it's about improving quality of life, relieving those symptoms, keeping people out of the hospital, slowing down the disease progression, and ultimately prolonging survival.
The approach seems to start with figuring out the why, treating underlying issues if possible. And your sources mention staging, A through D for stage C, symptomatic HFrEF. The focus is heavily on guideline-directed medical therapy, GDMT.
Absolutely. And non-drug measures are still vital. Restricting sodium, often to 2-3 grams a day, maybe restricting fluids if volume overload is bad despite diuretics, and daily weight monitoring is key. A sudden gain of a few pounds can mean fluid buildup. Stopping meds that worsen HF is also important.
Okay, let's get into the GDMT for stage C HFrEF. Your sources emphasize a core group of medications.
Yes, the modern cornerstone for HFrEF involves typically 4 classes of drugs taken together: an ACE inhibitor, an ARB or an RNI, a beta blocker proven for HF, an SGLT2 inhibitor, and an aldosterone antagonist, MRA. This combo has really changed outcomes.
And diuretics are used on top of that if needed for fluid.
Definitely. Diuretics are mainly for symptom control, managing fluid overload. Loop diuretics are the workhorses here. They don't have the same proven mortality benefit as the other 4 pillars, but they are essential for keeping patients comfortable and preventing congestion. Same potential side effects we discussed: electrolyte issues, kidney effects.
Got it. Now digging into those 4 pillars, ACE inhibitors and ARBs first.
Just like in hypertension, they block the harmful RAS system. Your sources confirm they improve symptoms, slow disease progression, and reduce mortality in HFrEF. They used to be the absolute first step after diagnosis.
But now there's the ARNI, sacubitril/valsartan, which seems preferred.
Yes, this is a major update your sources highlight. For eligible HFrEF patients, the ARNI sacubitril/valsartan is now generally preferred over an ACE inhibitor or ARB because trials showed it was superior in reducing hospitalizations and deaths.
How does it work differently?
It combines an ARB, valsartan, with a neprilysin inhibitor, sacubitril. Neprilysin is an enzyme that breaks down beneficial natural substances in the body that promote vasodilation and sodium excretion. So by blocking neprilysin and the angiotensin receptor, you get a kind of double benefit, enhancing the good stuff while blocking the bad.
But there's that important warning about switching from an ACE inhibitor.
Crucial point. You must stop the ACE inhibitor for at least 36 hours before starting the ARNI to minimize the risk of angioedema, that swelling reaction. No washout needed if switching from an ARB, though. Side effects are similar to ACE-ARBs: hypotension, kidney issues, high potassium, plus potentially cough and angioedema, maybe even slightly more often than with ACE inhibitors based on trial data.
Okay, pillar 2, beta blockers and HFrEF. We know they slow the heart, but isn't that bad if the pump is weak?
It seems counterintuitive, right? But specific beta blockers, the sources list carvedilol, metoprolol-succinate, the long-acting form, and bisoprolol are absolutely vital. They block the chronic damaging effects of the sympathetic nervous system on the heart, and despite slightly weakening the squeeze initially, they are proven to reduce mortality and hospitalizations long-term in HFrEF. Starting them requires care. You have to begin with very low doses and titrate up really slowly, maybe over weeks or months, to let the heart adapt. Patients need to know they might feel a bit worse initially before they feel better. Side effects: fatigue, bradycardia, sometimes worsening fluid retention at first.
Okay, pillar 3, aldosterone antagonists. The MRAs like spironolactone or eplerenone.
Adding a low-dose MRA is recommended for most HFrEF patients already on the other core therapies, as long as kidney function and potassium levels are okay and can be monitored closely. They block aldosterone, reducing sodium retention and cardiac fibrosis. They also reduce mortality and hospitalizations. Main risk, again, is hyperkalemia.
And the 4th pillar, relatively new but important, SGLT2 inhibitors.
Yes, this class drugs like dapagliflozin, empagliflozin, has been a game changer. Originally developed for diabetes, they showed remarkable benefits in HFrEF patients, reducing death and hospitalization whether or not the patient has diabetes. They work in the kidney, promoting glucose and sodium excretion, leading to beneficial effects on volume status, blood pressure, and directly on the heart and vessels. They're now recommended for essentially all eligible HFrEF patients.
So those 4 pillars are the foundation. What about other drugs mentioned in your sources?
Well, the combination of hydralazine and isosorbide denitrate is specifically recommended for Black patients with HFrEF who are still symptomatic on optimal therapy, and it can be an alternative for those who can't tolerate ACEI arbazernas.
Ivabradine might be considered to lower heart rate in the select group already on max beta blockers with a persistent high heart rate, mainly for reducing hospitalizations.
And digoxin, where does that fit now?
Your sources position digoxin as not first line for survival. It might be added to help with symptoms or reduce hospitalizations in patients still struggling despite full GDMT, or sometimes for rate control in atrial fibrillation with HFrEF. But it doesn't improve mortality.
And vericiguat.
That's another newer option, a soluble granulate cyclase activator. It might be considered in high-risk patients with worsening HFrEF despite other therapies to potentially reduce CV death or HF hospitalization based on trial data. But it's not a core first-line agent like the others.
What about the other type, HFpEF preserved ejection fraction? Treatment seems less clear-cut.
It is trickier. Historically, treatment focused on managing symptoms, especially fluid overload with diuretics, and controlling underlying conditions like hypertension. But your sources mention recent evidence supporting the use of SGLT2 inhibitors, MRAs, and possibly ARNIs or ARBs in certain HFpEF patients, showing some benefits for outcomes, though maybe not as dramatic as an HFrEF. It's an evolving area.
Okay, let's briefly touch on acute decompensated heart failure, ADHF, when things flare up.
Right, this is when symptoms suddenly worsen, often needing an ER visit or hospitalization, usually due to major fluid overload or sometimes low cardiac output. The immediate goal is stabilization. If fluid overload is the main issue, wet presentation, IV loop diuretics are the mainstay, often in higher doses or as a continuous infusion. Sometimes adding a thiazide diuretic can overcome resistance.
And if the issue is low output, poor perfusion, cold presentation.
If blood pressure allows, IV vasodilators like nitroglycerin might be used to reduce the workload on the heart. If the patient is in cardiogenic shock with very low BP and poor perfusion, then temporary use of inotropes drugs that boost heart contraction like dobutamine or milrinone might be necessary to support circulation. But your sources stress these are usually short-term bridges due to risks with long-term use. Trying to continue the chronic oral GDMT meds if possible during admission is also important.
How is HF treatment monitored long-term?
It's a combination of things, asking about symptoms, activity level. Daily weights are crucial for patients to track fluid status, reporting gains of, say, 2-3 pounds in a day or 5 pounds in a week. Regular lab checks for electrolytes, especially potassium, magnesium, and kidney function, are mandatory with many of these meds. And patience is needed, especially with beta blockers, as benefits build over time.
Whew. Okay, covered a lot on the pump problem. Let's move to the final part of this trio. Ischemic heart disease, IHD, the blocked arteries.
Right. This boils down to the heart muscle not getting enough oxygen and blood flow, usually because the coronary arteries supplying it are narrowed or blocked by atherosclerosis or plaque.
Your sources mention different flavors of this, including the really urgent ones, acute coronary syndromes or ACS that's unstable angina, and STEMI, which are types of heart attacks. And then the more chronic stuff like stable exertional angina.
Exactly. The underlying issue is usually that plaque buildup. Your material notes that plaques narrowing the artery by less than, say, 50–70% might not cause problems at rest, but they can limit flow when the heart demands more oxygen, like during exercise, causing stable angina.
But the ACS events, the heart attacks, often happen differently, right?
Yes, often it's not the most narrowed artery that causes the heart attack. It can be a smaller, less obstructive plaque that's unstable, maybe has a thin cap over a fatty core. If that plaque ruptures, it triggers a blood clot to form right there, suddenly blocking blood flow much more severely. That's the typical mechanism for ACS.
Okay. And variant or Prinzmetal angina?
That's a bit different. It's not usually a fixed blockage, but rather a temporary spasm of the coronary artery wall that clamps down, restricting flow, often causing pain at rest.
What does IHD typically feel like?
The classic symptom is angina pectoris chest discomfort, often described as pressure, heaviness, squeezing, tightness, usually felt behind the breastbone. It can radiate commonly to the left arm or shoulder, but also neck, jaw, back, even the abdomen. For stable angina, it's typically brought on by exertion, stress, cold, lasts maybe 5–20 minutes, and improves with rest or nitroglycerin. But importantly, your notes remind us some people have atypical symptoms, maybe just shortness of breath, fatigue, nausea, or pain in unusual locations. Especially women, older adults, and people with diabetes might present differently.
How's it diagnosed?
It starts with a thorough history, understanding the chest pain characteristics, triggers, relieving factors. Assessing risk factors is huge: age, sex, family history, plus the modifiable ones like hypertension, diabetes, cholesterol, smoking. An ECG might be normal at rest but show changes during pain or during a stress test. Stress testing aims to provoke ischemia safely. Coronary angiography is the gold standard to visualize blockages, but it's invasive. Other imaging like CT scans can also be used. Treatment goals. Pretty clear. Relieve the angina symptoms so people can live normally and, critically, prevent future events like MI, heart failure, stroke, and death by slowing down the atherosclerosis.
Non-drug approaches, again, are key risk factor management. Activity, diet, weight, definitely smoking cessation. For significant blockages causing major symptoms or high risk, procedures like coronary artery bypass surgery, CABG, or percutaneous coronary intervention, PCI, usually with stenting, can physically open up the arteries.
And pharmacologic therapy hits both risk factors and symptoms. For risk factors, aggressive BP control, goal 130/80, high-intensity statin therapy for cholesterol is standard, possibly adding ezetimibe or a PCSK9 inhibitor if goals aren't met. Good diabetes control, A1C target, often 7%, maybe 8% in some older complex patients. Flu shots annually.
And stopping clots antithrombotic therapy seems vital.
Foundational. Low-dose aspirin daily indefinitely is recommended for most with stable IHD. If aspirin isn't tolerated, clopidogrel is the usual alternative. After PCI with a stent or following an ACS event, dual antiplatelet therapy, DAPT, usually aspirin plus clopidogrel, prasugrel, or ticagrelor, is used for a period, typically months to a year, to prevent stent thrombosis. Your notes also mention low-dose rivaroxaban as an add-on to aspirin in some chronic CAD patients to further reduce events.
Okay, now the meds specifically for angina symptoms.
Beta blockers are usually the first choice here, according to your sources. They reduce the heart's oxygen demand by slowing heart rate and lowering contractility and BP. The goal is usually a resting heart rate around 50-60 BPM. They can be combined with other agents if needed. And remember, specific ones are needed if the patient also has HFRDF. Tapering off is essential.
Calcium channel blockers.
CCBs are good alternatives or add-ons if beta blockers aren't tolerated or sufficient. They also reduce oxygen demand, lower BP, wall tension, and can increase supply by dilating coronary arteries. DHP CCBs like amlodipine are often used. Non-DHPs like verapam, biltiazem are also effective, but generally avoided in HFrEF. Short-acting DHPs are a no-no due to reflex tachycardia risk.
And the classic quick relief, nitroglycerin.
Yes, sublingual nitroglycerin, tablet or spray, is essential for all patients with angina to treat acute episodes. Works within minutes by dilating veins mainly, reducing preload. It can also be used before activity known to cause angina. For chronic prevention, long-acting nitrates, pills or patches, can be added, usually with a beta blocker or a CCB. But the key with long-acting nitrates is that nitrate-free interval, usually 10-14 hours a day, where the drug isn't active. For example, patch off overnight or pills scheduled apart to prevent the body from becoming tolerant. Side effects are common: headache, flushing, dizziness.
What about ranolazine?
Ranolazine works differently, affecting sodium channels in heart cells to reduce calcium overload during ischemia. It helps reduce angina episodes without significantly changing heart rate or BP. Your sources position it mainly as an add-on therapy for patients still having symptoms, despite optimal doses of beta blockers, CCBs, or nitrates, or if they can't tolerate those traditional agents.
And for that variant prinzmetal angina, the spasm type.
Right, since it's vasospasm, drugs that relax coronary arteries are key. So CCBs and nitrates are the mainstays for prevention. Your notes clearly state beta blockers are not helpful and may even worsen spasm in this specific type of angina. Evaluating treatment involves checking how often angina occurs, how much SL-nitro is needed, and if exercise tolerance is better. Symptoms should improve over weeks once meds are optimized. Monitoring side effects is ongoing.
And there was that interesting sidebar on colchicine.
Yeah, it reflects the growing understanding of inflammation's role in atherosclerosis. Low-dose colchicine, an old anti-inflammatory drug, has shown in some studies that it might reduce cardiovascular events like MI and stroke when added to standard therapy in patients with chronic coronary disease. It's targeting that inflammatory component. Interesting development. So we've looked at each one, HTN, HF, IHD, but the really striking thing, as your sources show, is just how connected they all are.
Definitely.
Hypertension is a massive risk factor for developing both ischemic heart disease and heart failure. And IHD, especially having a heart attack, is probably the most common cause of developing HFrEF, that weakened heart pump.
It really is a web. You often can't treat one without thinking about or actively managing the others, and we saw that with the medications, didn't we? So many classes, ACE inhibitors, ARBs, beta blockers, MRAs, SGLT2 inhibitors, pop up and treat multiple conditions because they target these fundamental pathways, like the RAA system or the sympathetic nervous system, that are involved across the board.
Exactly. Understanding those links, which your material lays out nicely, Gives you that bigger picture. It's not just about treating high blood pressure or just shortness of breath, but managing the whole cardiovascular system and the processes driving these diseases.
Whew, okay, that really was a deep dive. We've covered a ton of ground on hypertension, heart failure, and ischemic heart disease, how they're defined, what causes them, symptoms, and really digging into the treatment strategies from your sources, lifestyle changes, all those drug classes like ACEs, ARNIs, SGLT2s, beta blockers, how they work, managing crises.
Yeah, we've seen how interconnected it all is and how complex treatment can be, really needing to tailor it to the specific patient, their type of condition, other health issues. It really underscores how dynamic managing chronic cardiovascular health is.
Totally. And hopefully breaking it down like this has given you, our listener, a much clearer, more solid understanding of these really important conditions and how healthcare teams approach them, all drawn from the sources you provided.
And here's something to maybe mull over, building on what we discussed. We talked a lot about guideline-directed therapy, but given the increasing understanding of genetics, biomarkers, and different subtypes of these diseases, how do you think personalized medicine might change the game in the future? Could we see treatments tailored much more precisely to an individual's specific biological profile, moving beyond the broader categories we use today?
That is a fascinating thought for where things might be headed. Great food for thought. Thanks for joining us on this deep dive. Keep learning, keep exploring.